Hi people, video after a long time, but yeah, let's go back to now studying for March 2024 exam. All the ADC candidates, new candidates, don't underestimate the importance of therapeutic guidelines. This is the book which you must be having. If you don't have, then this is a must book that you need to study to clear the ADC Part 1 exam. I've uploaded this book in the file section of the Target ADC Facebook group. You have to come in, join the group. It's a private group. Once you send a request, I will approve it. And once you get in, you have to go in the file section and you'll find many other books along with TG, a 2019 version, that's 2019, the latest version which was released. And yeah, you have to read this book at least 5 times. Now, see, what I've realized over a couple of months that many candidates read TG very properly, but they fail to analyze how to pick up the keywords from TG. When I say you have to read TG 5 times, it doesn't mean you have to read each and every word. It means that you do reading twice with all the words and sentences written. And the last 3 times when you're going to revise therapeutic guidelines, you must have marked important points. You have to read those important points and analyze what kind of questions would be asked. So, what I've done in this episode is that I have taken the first 2, 3 chapters of therapeutic guidelines and I have marked some important keywords and sentences, and I've made 5 questions out of them. Now, we are going to quickly go through these chapters, and then I will tell you which are the key areas you're supposed to focus on and start thinking how questions can be made from these things. And I've myself made 5 questions from this, and we are going to discuss them also side by side. So you will have an idea as to when questions are asked, uh, especially on in the cluster one of the exam from TG, why you still make a mistake in spite of knowing the theory. Okay, so let's start. Now, coming to the first chapter of therapeutic guidelines, it says principles of diagnosis and management in dental practice. Now, you'll be going through this. For me, the important lines here would be the process of establishing a diagnosis begins by digging a thorough history. Now, therapeutic guidelines have clearly given here a sequence of how to approach a patient and establish a diagnosis when he comes to you. So, firstly, when a patient is going to enter your clinic, even though the patient says, I'm having a severe pain, for example, in my left lower molar, how are you going to proceed towards it? You will not be asking the patient directly to jump on the chair, open the mouth, and you start taking an x ray. No. So, what are the sequence? You start by taking a thorough history. Then you conduct a clinical examination. After you are done with the clinical examination, then you perform diagnostic test. Now remember, X-ray is a diagnostic test. It's not a clinical examination. So step one, you take the history of entire. When I say history, it's personal, it's social, it's medical. All these 3 histories have to be taken properly. Even though the patient may keep on insisting, no, you directly jump onto the tooth which is hurting me, why bother taking an history? No, you have to take an history. And this is very important in your ADC Part 2 exam OSCEs as well. So, yeah, you have to follow the sequence. Now, why the sequence becomes important is because a question can be fabricated from this. And I'll show you how that question would be. And these kind of questions have been asked in the exam. So, knowing now what is the sequence in TG, see, it was written in therapeutic guidelines, just black and white. But your mind has to understand the intelligence of this, that how questions can be fabricated just on the basis of these 3 sentences. Let's see a question. Mr. Dave, a 50-year-old, presented with severe pain in 3/6 tooth. Now, you see on IOPA, he's carrying an IOPA from some other clinic, for example, and it's grossly carious, and patient wants to proceed for pulpectomy. Now, but he's coming to you for the first time, correct? While taking his medical history, he says he has hypertension and is taking his medicines, but not regularly. Your next step to manage this case would be, so imagine you are the dentist, a patient comes to you having an IOP from another clinic, or you don't know the timeline when it was taken, but he has an IOP and he says he's in severe pain. And he's like, do something about it, doctor. So what are you going to do because you already have an IOP? First, do pulpectomy straight away. Second, give him medicine to relieve the pain. Third, refer him to GP to get clearance for his hypertension. Fourth, do emergency pulpotomy to relieve pain and then refer to GP because the patient is in a lot of pain, and give LA without adrenaline. See, now we are going to eliminate each option. We are not going to directly jump. The common mistake that people do while solving ADC paper is that if they find one answer is correct, they'll jump onto it. No, you also have to eliminate the other option because ADC is a tricky exam. They very rarely give you a straightforward question. So if I were to jump onto the option of pulpectomy, why I should not be doing that or why I should be doing that? I have to analyze both my uh, strategies. So pulpectomy is not a wrong option, but do I have the entire clinical examination, diagnostic test, and most importantly, the diagnosis that I'm going to start this treatment? Now, what does the question say? While taking his medical history, he says he has hypertension and he's taking medicines but not regularly. So now even if you have to extract a tooth or do pulpectomy, you'll have to give local anesthesia. And you have to make sure that the patient is in good fit condition to take that. How would you know the patient is in a fit condition if the patient himself says he's not taken his medicines regularly? If the hypertension, the blood pressure is really high, you would be in more trouble for starting the treatment because you didn't take the history properly. Now, since the patient is not giving a history properly, and even though he's in pain, what are you going to do? Can you start pulpectomy? No, that would be wrong treatment. Even though maybe your diagnosis would have been irreversible pulpitis, but you still can't start the treatment unless you have a complete history. Give medicine to relieve pain. Again, this is not a wrong option, but do you know if whatever medicine you're going to give him is not going to create more trouble for him if his hypertension is uncontrolled, and you don't know if it's controlled or uncontrolled because he has not been taking his medicines regularly? Third option, refer him to GP to get clearance for his hypertension. Seeing the overall picture of the health of the patient, this becomes a more appropriate choice of answer because unless you know for sure that the hypertension is proper or the GP has given the clearance, you just don't start any treatment. Or if there was an option saying consult the GP over the phone and then prescribe him medicines, that would have also been a good answer. B, do emergency pulpotomy to relieve pain and then refer to GP. Very tempting option. But again, to do an emergency pulpotomy, that is basically root canal opening, you will have to give local anesthesia, which brings us back to the fifth option, give LA without adrenaline. You will not give any local anesthesia with or without adrenaline unless you know for sure that the patient is fit to undergo any kind of treatment. So a GP clearance becomes mandatory. So even though the patient is in severe pain, maybe having an IOPA, you have to follow therapeutic guidelines which says that first establish a diagnosis by taking a thorough history. If you don't have a thorough history, you would not go ahead and do anything else. Is that clear? So this is where people make a lot of mistake in spite of things properly given in therapeutic guidelines. So if you're going to read further, here it's written clearly, taking a history. Taking a history means taking the overall history, medical history, comprehensive prescription medicines, over-the-counter medicines, assess the capacity of the patient, whether he's giving an accurate history or not, consult with patient's GP if you are confused, you know. So you have to make sure that all these points are covered before you start any kind of treatment. Now coming to dental practice examination and diagnostic test. Now here there is another important statement which you should underline. Choose the tests that are evidence-based. Involve the patient in the decision to undergo a test. Very important. You should always take consent of the patient to undergo a test. Now, the clinical benefit of performing a diagnostic test should outweigh any associated risks. Meaning, even if a test is causing some side effect, if it's really required for you to undergo a diagnosis, then you have to take it. Cumulative radiation exposure, particularly in childhood and adolescence, has been associated with an increased incidence of cancer. So, aim to achieve the lowest possible radiation exposure while maximizing the diagnostic value of the test. Now, here again, the sequence is examination and diagnostic test. So, you will have questions coming like a patient has come to you for examination. Let's see, I think I have prepared the second question based on that. Yeah. Now, in the same patient who had come before to you, to confirm the diagnosis, which is the initial diagnostic test that you would be doing. Now, what did we read in therapeutic guidelines and all these things? That radiation exposure should be minimized unless it's really, really required for you to ascertain your diagnosis. So, when the question is asking you, which is the initial diagnostic test you would do to identify the problem in the tooth to reach a diagnosis, they are not asking you which all diagnostic test you are going to do. They are asking which is the initial, that is the first diagnostic test. Most of the candidates just read the question without seeing the keyword, and the keyword here is this initial. Now, percussion, palpation, IOPA, biting, cold test, all are diagnostic tests. None of them is wrong, but which would be the initial test that you would do? So, if you have been following therapeutic guidelines and have read the statement very nicely, you are going to go ahead with cold test. Because if the patient has come to you with irreversible pain, etc., cold test on the particular tooth is just going to give the answer right away. Percussion, palpation, biting test will come after the cold test, and IOPA will come at the last. You understand? None of the tests are wrong, but then don't be confused. And I see many people being confused. Doctor, which test we should be doing first? Understand the sequence. Therapeutic guidelines has given you the guidelines to do that. If you will read that properly, then you will never have any problem. This is what I keep on saying. Understand the concept. Don't mug up the answer, because based on what is provided, 10,000 questions can be formed on this. If you know the concept, if you know the sequence, hierarchy, and the priority of things that are to be taken, you will never mark any answer wrong. I hope this is clear. Moving on. Let's open this again. Yeah. Why is this going down? So after this, I think I've already made a video about steroids in dentistry. Go ahead and read that. Now, I would like to discuss about medicines. Coming to painkillers. See, in the sequence of therapeutic guidelines, the textbook itself, the importance of pain is very, very significant. So immediately after principle and diagnosis, they have introduced a chapter of drugs used to treat acute pain in dentistry, because the patient 90% of the time comes to a dentist because he is having some kind of pain. And then even though for various reasons, if you're not starting the treatment on the same day, you are expected to give them a pain med, right? So you should know when you in a dentist capacity what pain medicines you can give, and in which conditions what medicine you have to give. So overall, we are left with two classes of drugs. One is paracetamol, and the second is non-steroidal anti-inflammatory drug. NSAIDs, which we call it as. Paracetamol is not an NSAID. Understood? Paracetamol is a different kind of drug. It doesn't fall into NSAID category. Paracetamol is usually the preferred choice of drug, but sometimes in acute dental pain, paracetamol is not the preferred choice of drug. NSAIDs are the ones which are preferred choice of drugs, which is mentioned in therapeutic guidelines. Understood? So you have to know some things about NSAIDs. They are classified into two groups, non-selective and selective. Why this is important, you'll come to know later. Ibuprofen, naproxen are non-selective. That means they will act on both COX-1 and COX-2 receptors of the body. And now COX-2 selective is the one which will act only on COX-2 receptors in the body. So COX-2 selective is celecoxib. Understood? Now let's move on to some important lines. Now, usually a dentist can prescribe an NSAID. Now there is a nice box given here which you should memorize, and I've made a question on that box also. Patients who should not be given NSAID by a dentist. Where the box went again. Corticosteroids you'll study on your own. Like I said, I've already mentioned this in one of my videos, so you'll get that. Details about it. I think this is up. So yeah, again coming back to the box. Patients who should not be prescribed an NSAID by a dentist. These patients, kidney impairment, heart failure, GI bleed, corticosteroids, multiple risk factors, especially in elderly patients with history of GI bleeding. I want you to focus on this line, patients taking corticosteroids, because though you may remember the others, high chances of you forgetting that if a patient is taking corticosteroid, you are not prescribing NSAID. You're going to refer the patient to a general practitioner who will decide what medicine can be prescribed. Can you prescribe opioid to a certain extent? Yes. But is that your first choice of drug? No. Can you prescribe opioid by yourself? Yes, you can. But is it better to consult a GP? Yes. So remember this sequence. Now, coming to a question which I formulated on this. Patients who should not be prescribed an NSAID by a dentist. Heart failure, GI bleeding, bleeding disorders, severe kidney impairment, corticosteroids, all of the above. We just discussed that all of these key points, you should not be prescribing an NSAID. So in your notebook, I'm sure you must be taking notes from therapeutic guidelines. Mention all this. That box is very important. So there we solve question 3. The answer is all of the above. Now coming back to NSAID, you can just go through all of these things. Yeah. Pregnant woman question 100% is going to be asked in your ADC exam. Minimum 1, maximum 3 or 4. So so when you're going to read this paragraph, one important thing that the therapeutic guidelines mention is that do not use NSAIDs in pregnant women beyond 32 weeks of gestation. Very important. So there can be a question which can ask you, all are true about NSAID except. NSAID is a preferred drug for acute dental pain. True. Ibuprofen belongs to non-selective NSAID. We learned that in the first paragraph. True. Celecoxib belongs to selective NSAIDs. Correct. In a pregnant woman, non-selective NSAID is preferred. Now you may be confused. Is it true or it is not? It is true because you have to read it here. So when you're going to read this pregnant woman case, you're going to find in this paragraph that a non-selective NSAID is preferred if you have to give NSAIDs. Okay, so now you see the importance of ibuprofen, naproxen, and celecoxib. I have mentioned here non-selective NSAID is preferred. I can also write here in a pregnant woman, ibuprofen is preferred or naproxen is preferred. So you have to realize that it's a non-selective. If I had written in a pregnant woman celecoxib is preferred, then it's a wrong answer because selective NSAID is not preferred according to therapeutic guidelines. Hence, you have to remember the names of the medicines which fall into the selective and the non-selective group. Last option, NSAID is safe beyond 32 weeks of gestation, and we just read it is not. You're not supposed to use it. So that becomes my answer of choice. So the rest of the statements were true, but this was not. So this is how my marks are. I've made this mock specifically for therapeutic guidelines because I realized, like I mentioned, you guys like read the theory, but you fail to understand what kind of questions can be formulated. So I want now, whenever you read even a single sentence of therapeutic guidelines, think what question can be asked based on this. Okay. Now coming to, so read once all of these things. Yeah, now this two particular paragraphs become very important. You have to avoid non-selective NSAID in case of increased GI toxicity and bronchospasms. So non-selective NSAID is preferred in pregnant women, but it is to be avoided in case of GI toxicity and bronchospasm. So my last question is based on that. Following is true about NSAID. So my earlier question was what is not true. Now this is what is true. Now this question and the options here should be in your notebook because I've actually mentioned the key points about NSAIDs here. So following is true about NSAID. In patients at risk of GI toxicity, non-selective NSAID is avoided. Correct. In patient with risk of GI toxicity, COX-2 selective NSAID is preferred. Correct. It's mentioned in TG. In a patient with bronchospasm, use COX-2 selective NSAID. Correct. In a pregnant patient, non-selective NSAID is preferred. Correct. All of the above options are true about NSAID. Correct. So my answer will become all of the above. So these 4 lines will make the crux of your NSAID. So basically all the 5 questions provided by me are the important topics that you're supposed to remember from this first 2 chapters of therapeutic guidelines. I hope you have a better idea now how to read therapeutic guidelines, how to formulate in your brain what questions can be asked from this. So I've just taken an overview. This was I've already made a video on corticosteroids in dentistry from therapeutic guidelines. Go through that video. So thereby we have completed like 5 chapters from therapeutic guidelines. My next video would be from mouthwash to dental caries. And I've already made a video on ICDA's classification, but we can of course revise that. So I hope this is very clear for you. And yeah, wait until my next video. In the meanwhile, start reading therapeutic guidelines the way I have asked you to. Best of luck for your exam, guys.